Good afternoon, everyone. I'm very pleased to welcome you all to this webinar. My name is Olga Kubasova, and I'm the founder and CEO of Image Analysis. Today, Michael Boson from the Parker Institute will be joining us to provide clinical insight on the use of dynamic contrast-enhanced MRI in musculoskeletal applications, such as inflammatory arthritis. Then Mark Hinton, Image Analysis CTO, will explain quantitative pharmacokinetic analysis method and show how to compute these parameters using oncology dataset so you can link two methods together. On the 23rd of October, we will run our next webinar where we will discuss how to quantify MRIs of spondylar arthropathies and arthritis. Before we begin, let me give you a brief overview of Image Analysis. The company was founded in 2007 after I completed my PhD in computer science, working very closely with several institutions, including the Parker Institute, who were interested to understand if there is a better imaging modality for visualization of soft tissue inflammation than X-ray. The answer, of course, was MRI. With MRI, and in particular dynamic contrast-enhanced MRI, we were able to visualize in 3 dimensions soft tissue such as synovitis or bone marrow edema. The next question was how to quantify this information so that the patients can be followed up and the effect of the treatment objectively measured. Our long-standing academic collaboration led to the development of commercial software, Dynamica, which incorporated a number of algorithms for quantification of static and dynamic MRI. Dynamica has been sold to a number of radiology and rheumatology departments in the first 2 years of the company existence, and we had over 40 clinical installations. While we have started working with radiologists and rheumatologists specializing in inflammatory arthritis, very soon we saw Dynamica and the quantitative techniques used for measuring the size of the lesions in ankylosing spondylitis studies, or quantification of nail bed enhancement in psoriatic arthritis. Most recently, we finished this first study on quantifying inflammatory activity in osteoarthritis patients. Dynamica is now used in large cancer centers to provide sensitive information about tumor tissue. However, we always felt that our users needed more support, especially with imaging data acquisition, setup of scanners, overall analysis of the results to identify patient subgroups, and to distill more information about the treatment effect. So Image Analysis team set to deliver a full service for an MRI-focused study, which included helping to set up right scanning sequences, developing imaging protocols, ensuring imaging quality, and of course, in the center of it all was always quantification of MRI data using objective and sensitive markers. We now work with major biotech and pharma companies, providing end-to-end service for MRI part of a clinical trial, as well as with investigators, researchers, and doctors who use Dynamica in daily practice and R&D projects. For the researchers, we released a free version of Dynamica, Dynamica Open Access, to give you an opportunity to process up to 20 MRI images. This is a cloud-based solution which requires no installation and works in real time. We plan to run at least 2 webinars per month, giving you an opportunity to learn about Dynamica functionality and, of course, try it in your work. All your feedback is more than welcome. Lastly, I would like to invite you to meet us at ACR in Boston and RSNA in Chicago, where we have a booth and presenting several abstracts where our investigators use Dynamica in their studies and trials. Right, we will start this seminar with a 50-minute lecture by Dr. Boson, who is the head of MSK research and consultant radiologist in the Department of Radiology of Frederiksberg Hospital and Parker Institute, Denmark. His PhD and special interests include rheumatoid arthritis, osteoarthritis, psoriatic arthritis, and quantification of MRI data using advanced imaging techniques. With over 12 years of hands-on experience in imaging protocol design, imaging study setup, scoring, and reporting, Dr. Boson authored over 40 papers and has been an invited speaker in national and international conferences. Let's welcome Michael.
Hello and welcome to this introduction to dynamic contrast enhanced MRI in inflammatory and degenerative joint disease. The overview of the presentation is first of all a little background about imaging in inflammatory joint diseases, then a short introduction to how we use dynamic contrast enhanced MRI to quantify inflammation and how we map it. And I will try to give you the lesson we learned from inflammatory joint diseases and then cross over with perspective to degenerative joint diseases. In early RA, usually you start with an X-ray, as you can see on your left hand. If you do MRI in the same patients that has high disease activity, you will see on the fluid-sensitive images like STIR that you have both severe synovitis as well as bone marrow edema in the joint. The reason why we should give contrast is the fact, as you can see on your right, that fluid-sensitive images will not be able to discriminate synovitis from fluid in the joint cavity called diffusion. So you will actually overestimate the degree of synovitis if you only rely on the fluid-sensitive images. Another important issue and reason for why we should use MRI in inflammatory joint diseases is that X-rays that are usually recommended and used for monitoring and quantifying the disease underestimate the degree of erosions. As you can see here in the third MTP joint, the X-ray is negative, whereas the MRI reveals an up to 50% erosion involving the head of the third metatarsal bone. Another, let's say, example of that is if we zoom in on an X-ray, you can see where the arrows point that you will have an erosion here in this part of the bone, and then you will also see on this the same MRI that you have synovitis around that bone, which is black on T1 weighted images, meaning that you have a bone marrow edema. Another thing you can't see on the X-ray is this bigger erosion here inside the same bone. And if you do the STIR images, you will see that the bone is all bright, meaning that you have a severe bone marrow edema. Thus, looking at these results, the MRI was done 20 months prior to the X-ray, which also is stated in the literature that you see erosions up to a median of 2 years before on MRI, then you'll be able to see them on the X-ray, if you see them at all. Another X-ray feature is that you usually map the joint space narrowing if you do the Van der Heide and Sharp score. And joint space narrowing in a joint that has a very thin cartilage can be very difficult to assess. And in this example, you will see a simulated or computer simulated normal joint on the upper left hand, and then a 75% reduction, a 50% reduction, and a 25% reduction. It might be difficult because this is a slowly progressing disease entity that happens over time. If you have too short intervals between your X-rays, you'll never depict the real reduction in the joint spaces. There's also an unsolved problem with observer variability. As this publication from 2004 stated that the variability in scoring radiographic abnormalities is considerable among a group of 11 experts. And these experts are one of the pioneers and the reference persons in the field of X-ray, like John T. Sharp, Van der Heide, Vibeke Strand, Marisa Lasser, and so on, Arvi Larsen as well. So they stated that this was a problem, and it has important implications when you actually do your power calculations in studies. Then also what opens up for more use of sophisticated imaging like MRI and ultrasound in inflammatory joint diseases is the new RA-ACR and EULAR criteria that was published in 2010. And they state that X-ray of the hand is not part of the criteria unless you have a typical erosions, and usually the patients will come and you have a baseline X-ray. So if you see an erosions, this will point towards an erosive disease entity. But if you don't see an erosions, it really is not what you classify the patient's disease from. But it's defined on joint involvement, counting the number of joints that has swelling and tenderness. And if you don't have enough points, you'll be able to now use MRI and or ultrasound to have more joints with synovitis to confirm the clinical findings. When we talk about erosive disease, it's also very important that you try to optimize the MRI sequences you have, because erosions in complex joints like the wrist joints are very difficult to see, because you have a lot of curvatures in the bones that can be, let's say, easily interpreted as an erosion, but could be due to an anatomical anomaly or the insertion of a ligament. So what you will do, you have to optimize the sequence to have a low slice thickness and with a very high matrix. If you do that, you can actually achieve good quality in even less scan time than the conventional MRIs that the vendors provided us with. Having done that, you can even on low field systems of 0.2 Tesla, like this case, you can assess the erosive change over time. And what you'll see here is that this erosion progresses even within 1 month of study. So this also underlines the fact that inflammatory joint diseases are aggressive local diseases that can erode the bone in a very short time span if you don't suppress the disease activity. How do we quantify synovitis then? Well, having crossed the boundaries of giving contrast, then what you do, you assess the volume of enhancing synovium or pannus when you have had the disease for some time. And that volume will, at least in the beginning of the disease, fluctuates. So when you have disease activity, it will swell up and give a higher volume than when the disease activity is treated, where the volume then will be reduced, as in the case here to the left, baseline and 4 weeks after the injection of a steroid. We see a definite change in both the bone structure but also on the synovial volume. But in the same patients, further inside the joint, in the mid-carpal joint, you'll see that slice positioning can be difficult. But here you see the erosions in the capitate bone, and this is an erosion that will show you a lower thickness of the synovium in baseline and a higher thickness in follow-up. Also in the dorsal side of the wrist bone here, you see that again it seems that there's a larger volume of enlarged synovium than on the baseline scan. So are we talking here about a slice positioning area, or are we talking about actually progression in the synovitis in 4 weeks? This is very difficult. Treatment effects is also difficult to assess when you have the disease for some time, because if you only look at the volume of the synovium, then having had the disease for some time, you will have continuous remitting, relapsing activity, which will grow the pannus, and it will heal with fibrous tissue or scar tissue, and thus the the synovium will not fluctuate in volume as much in a future flare-up. As you can see down here in baseline scan with a high activity, because you have a lot of bone marrow edema in these patients, and then on biologic treatment after 1 year, the bone marrow lesions or bone marrow edema has been reduced a lot. It's fully gone after 2 years, but look at the synovial lining down here. It's completely unchanged over time, meaning that if you only assess the volume with a score, you will not be able to see the true change of that. Whereas the bone marrow edema seems to be more fluctuant, but again note that it takes a lot of time actually for the bone marrow edema to fully disappear. This could be due to the fact that bone marrow edema is not only due to inflammation, but also due to a repair process. Then, can MRI provide the same information as we have from ultrasound Doppler? Because the ultrasound Doppler is giving us the actual flow in the pannus. You can see here in this subluxed MCP joint with a hypoechoic synovium that you have a lot of Doppler activity when the patient has symptoms. Then you inject steroid, and after 4 weeks, you see that the Doppler activity has disappeared, but the hypoechoic part is unchanged in volume. So, why is this important? Well, perfusion is important. We have always believed, but it's really underlined with this heavily cited publication from 2008 from the Leeds group, where they showed that subclinical joint inflammation assessed by imaging, MRI and ultrasound, explained structural deterioration in rheumatoid arthritis patients in clinical remission who received conventional therapy. And actually, the ultrasound Doppler when the patients were in remission, if you still had that Doppler activity, then you had a 12 times higher odds ratio of deteriorating on the X-rays after 1 year. So this is very important to use fusion technologies to capture these patients in clinical remission. We also know that the Doppler can predict the treatment effect from an anti-TNF-alpha drug, meaning that if you have a high Doppler activity, you also have more inflammation and thus have a higher chance of having an effect of a TNF-alpha drug. So perfusion with MRI is, in a popular term, a way of giving ultrasound Doppler flow informations in the MRI images, with the obvious advantages of the MRI images being a three-dimensional technology that can assess all joint structures involved in the disease activity. And the basic principles is that you take a T1 weighted image around an anatomy, and then you do a lot of images in that same anatomy while you inject the contrast. And this will give us an opportunity to visualize the contrast behavior like you see here in a movie. But having that data information, you will also be able to assess how the flow curves in every voxel of that image is behaving. The background of dynamic contrast enhanced MRI, which is not a new technique, it was actually evolved and used a lot in the 1990s, is that it's based on this sequential acquisition of rapid MRI sequences before and during the infusion of a contrast agent. The dynamic contrast enhanced MRI also in the 90s was shown to correlate with the synovial vascularity and inflammation, and here in particular it was the slope of the enhancement curve. They also have been tested in both high field and low field scanners and have given clinical meaningful information, and were able to separate patients in clinical remission and those with clinical activity. The problem with the old way of doing it in the 1990s and beginning of the zeros was that it was analyzed using a region of interest, where a small up to a few millimeters region of interest was placed in the most enhancing part of the synovium, which was chosen by eyeballing the data, or making as I've showed you before, the small film, and then placing the ROI. But the problem with that approach was that just moving the ROI a little bit or redoing the ROI gave up to 50% of difference in results, which was not clinically useful and also poses some problems in clinical trials. But this, with the technological advantages and the better computers, seems to have been overcome with the introduction of Dynamica, where movement correction of the dynamic data and a voxel-by-voxel imaging analysis test with a model approach have really opened up for using this old technology again. What you can obtain from either a region of interest, a ROI, or from every voxel is a flow curve. So you start with a baseline. If you do voxel-by-voxel signal intensity analysis, you don't need an arterial input function as you do when you do K-trans. But you start with the patient's baseline, and the baseline actually is chosen to map the slope and the plateau of the enhancement curve in every voxel. And from the patients with high disease activity from before, you saw that here an example of 0, 15, and 300 seconds. If you place a ROI in this region, eyeballing the data, you will have a very steep enhancement curve. But what the data previously also showed that if you choose your slope of the curve 55 seconds after it began to enhance, then you had the best correlation to histology. But the problem with this approach is that you underestimate the high degrees of inflammation, because here you can see that the true curve has a much steeper inflow than if you draw the curve after 55 seconds of when enhancement begins. And this corresponds very well to a very high Doppler activity in the patients. In another patient where you can see that the patient is in subclinical activity with a DAS28 score of around 4, 3.8 to 4, you can see that the enhancing synovium in the erosion in the trichotillomere bone really enhances, and if you address the volume or assess it, you will have a degree between 1 and 2. But as you can see, if you place a ROI inside that particular erosion, you will have a very flat curve. That corresponds quite well with the 55 seconds. And here again, you have no Doppler activity. The DCE-MRI maps with a model-based analysis is based on, let's say, 3 different enhancement properties. And first of all, you see that you have a baseline, which you don't give any color. Then you have a continuous uptake while you image. If the contrast or the voxels continue to have higher signal intensities, then you will give them a blue color. If you reach a plateau and do not wash out in the time you image, you will have a green color. And if you reach a plateau and then also begin to wash out in that particular voxel, you will be given a red color. And this is applied in the DCE-MRI gadolinium map. And the gadolinium map will show us the volume of enhancing voxels and the behavior of the contrast over the time you image. Obviously, this will change from if you use only 1 minute of DCE-MRI data analysis to if you, for instance, as we recommend, use 5 minutes, because this is the time interval where usually intravenous gadolinium contrast agents has reached equilibrium in normal tissue with the extracellular tissue. What you can also do is you can look in every voxel how the contrast behaved. So what you have a baseline, then you will have an initial rate of enhancement until you reach maximum enhancement or reach plateau. Then you will have a plateau phase, and if you have a washout phase, you will also have an initial rate of washout, and you can assess the time in between those entities. And then again, finally, you can calculate the area under the curve. And usually what we have done, we have used the map of time to contrast onset, the maximum enhancement map, and the initial rate of enhancement map. And this will add dynamic properties to the gadolinium map and help you interpret how the contrast behaved over time. Another thing that you can use if you don't do dynamic MRI images or only do pre and post contrast is that with the built-in movement correction, you can have more robust subtraction images. And from the subtraction images, you can again get a volume of enhancing voxels. A very important step in dynamic contrast enhanced MRI is that an anatomy that you image, even though it's a knee or a hand that you think lies still, have micro movement. And micro movement will really influence your curves if you look at every voxel. As you can see here in your upper left corner, you have an actual view of an MCP joint before and during a contrast injection. And if you place a ROI, for instance, around this second MCP joint here in red, you see that the crude curves without movement correction or registration will give you this mean curve in bold. But there's a very large range in these curves. If you take one slice and then use that as a reference and then let's say movement correct all the other slices in the time series to that frame, you will change the curve of the signal intensity. And you will approximate the voxels to each other, meaning you will gain a lot of signal. We did in over 100 patients this analysis and found that we could reduce the movement artifact in 3 planes from 7 millimeters to 1 millimeters of shift and up to from 7 to 1 degrees of rotation, which gave us up to 300% more signal in the images. And this is especially important if you use low field images to do this analysis, because they actually come with a lower signal to noise ratio. But beside of giving you the better signal to noise ratio, it will really also impact your classification of voxels. Because as you can see here in a low field data set, without movement correction, even on the residual marker, it seems that it has enhancement. And this is due to the micro movement. And you can also see the skin surfaces and the bone soft tissue intervals. They will all, let's say, show signs of enhancement. But if you do the registration in this patient in remission, also in imaging remission, you'll see that no enhancement takes place. And most of this artificial enhancement due to movement has disappeared. But you also have impact on classifying the patients from moderate to high disease activity, as you see in the upper row here, rheumatoid arthritis patients with high activity. If you don't do the movement correction or registration, you'll see that the more reddish, dark red colors, they show you that you have not as high contrast uptake or not as steep contrast uptake. But if you do the movement correction, you'll suddenly see the need is of very high contrast uptake. And it also has implications on the healthy controls, because the healthy controls seems to have some kind of contrast enhancement, but when you do the registration, you'll see that you only have contrast enhancement in the subcutaneous skin areas where you should have, because you have the vessels. It can also aid you in saving your data, and saving your data is another issue, because you only have one time, you only have one chance to get DCE-MRI data when you give your intravenous contrast. If it is too late to do the DCE-MRI after you've given the contrast, because you need the reference of the baseline before contrast. So here a case where the patient moved in the examination, and in this MCP joint you see a heavily enhancing synovium with a strange enhancement curve. Seems like a mixture of material curve or whatever. But when you do the registration, you see a much more smooth and more expected curve after the movement correction. As I told you, the DCE-MRI method is applicable in every anatomy that you can think of. It doesn't necessarily have to be applied in inflammatory joint diseases. It can also be used in cancer, or oncology, infection, and in autoimmune diseases of other areas. But one thing is important is that you need to have the patients, if you want to measure change, you need to have them on the same scanner field strength, because the T1 value which you map with DCE-MRI is different between the field strength, meaning that your curves are not comparable with each other, at least not the true values. Maybe the shapes are, but we still have to look into this. So one recommendation is that you stay on the same scanner and monitor the patient's treatment effect using the same scanner and the same set. We do in our center dynamic MRI in using all different kind of field strength from 0.2 Tesla to 3 Tesla, and we have protocols developed for that, which we are happy to share if anyone would like that. Well, how can you use it clinically then? Well, first of all, as I said before, DCE-MRI is an add-on technology to a post-contrast static sequence. And it actually only takes 5 minutes of extra scan time if you do the DCE-MRI contrast while you do the contrast injection. And we have already shown that you need to give contrast, because otherwise you will overestimate the synovitis activity if you have effusion in the joints. So here we have a case done on a low field scanner, where you can see that the static post-contrast T1 weighted images in the lower left corner at baseline, day 1, day 2, and day 7, after we injected at baseline a steroid into the knee joint, ultrasound guided. And you can see the enhancing synovial membrane with the arrows pointing at it. It is smooth, it is not that thick, below 2 millimeters, so this corresponds to a synovitis degree of 1. On the upper row, you see the corresponding DCE-MRI map of maximum enhancement. And what you will see from baseline to day 1 is that the effusion, which is the dark or hyperintense part here, will be reduced because we took the effusion out while we had this syringe in the joint with ultrasound. But what happens after that? You'll see you have a 50% reduction in the ME signal, even on day 1. On day 2, the perfusion is so low that it's basically not detected in the synovial lining. You still have enhancement corresponding to a degree of 1, and that enhancement is still visible on day 7. And usually the synovial lining is not visible in normal subject, so this will always also correspond to a static score degree of 1. but you see on the upper right that the fusion has been shut down as expected from a treatment effect, because the patient on day 2 had reduced or almost diminished symptoms. And it's not an artifact, as you can see, because you have the vessels behind the knee joint that should always stay open on a physiological level as your reference. You can also begin to monitor what happens with an inflammatory treatment response on other treatments than steroid, but you have to take into account here that steroids shut down most pathways involved in the inflammatory cascade. Then a TNF-alpha inhibition or an IL-1 or IL-6 or CD20, what you could think of, will only take one pathway away, which means that it will take a little bit longer time for you to see the treatment effect. But baseline before infliximab treatment, after 1 month, you see and can measure a reduction both in volume and in dynamic properties, but it's more pronounced on the 6-month follow-up. So what you also can see is that going to a high field strength is you can scroll through the full joint and map how the typical rheumatoid arthritis patient look like, because a higher field strength means that you can, with the same time scan, time between the dynamic MRI sequences, you can cover a larger area. And we are able to cover the full extent of a hand or a full knee with less than 10 seconds between the dynamic acquisitions. You can also use it and map other disease areas like osteoarthritis in your upper row, see the CMC1 joint infection, the dip joint involvement, a little bit of the tendon sheets and the muscle of the thenar muscle. Rheumatoid arthritis patients with low activity, there's some enhancement still due to you have volume or enhancing kinase, but very low perfusion in those areas. Another rheumatoid arthritis patients with a MCP joint and PIP joint distribution with moderate activity, and in the lower corner, and another patients with high activity also involving the muscles. And if you do, like we do, usually a coronal view of the hand, then you're also able to assess multiple anatomies from the wrist to the MCP joints, which you are not able to do if you choose an axial view. The axial view will though help you to better separate the tendon sheets from the synovial lining, but that's what you have to consider when you do your protocol, which are the tissues you would like to address most. But what you are able to see where the arrow points is that you can, when you do your region of interest analysis, you can separate the enhanced synovium from the vessels, which are tube-like structures that has a washout pattern of enhancement. You can also use the dynamic MRI to assess the treatment response. If you don't address the anatomy of interest, then usually you don't have as good a treatment response as you would have if you, for instance, locally inject an anti-inflammatory injection directly into the tissue of interest. And in this case, you see that there's a high tenosynovitis involvement in a patient, and also some wrist joint involvement. Usually when you inject these patients, you inject steroid here between the lunate bone and the radius, and this patient was suspected to have inflammation in the wrist because that's where the symptoms were tenderness and swelling, but you could not, based on your clinical examination, actually assess the tenosynovitis. And what you saw on the 14 days follow-up, or sorry, the 1 month follow-up, was that the synovium in the treated wrist has diminished a lot, but the tenosynovitis has not been affected very much, and could explain the partial response in the patient. You can also use if you cover a larger area, use the dynamic MRI maps to assess how the contrast behaves in all the slices. And in this case, as you can see down here with the initial rate of enhancement map, reflecting the steepness of the enhancement curves in the voxels. So the brighter the colors, the steeper the curves. You can see that there's a distinct difference even between slices. And this is a thing that we need to look more into, because when you have a full volume, you might have pockets of welling synovium and pockets of highly active synovium that are not easily assessed if you only use ultrasound, because it only sees the surface of that. You can also find the patients that have clinical response but still have signs of inflammatory activity using the technique. In this case, you see a baseline, a patient before starting biologic treatment. You have some wrist joint involvement along with some tenosynovitis, and especially notice the MCP2 and MCP3 joints with very high inflammatory activity. The patient goes into clinical remission after 3 months of biologic treatment, are happy. But what happens to the MCP joint is you see a huge reduction in size of the synovium and also in the activity in the second MCP joint, but a very highly still active MCP3 joints where you have an erosion developing. And finally, you see that the synovitis and tenosynovitis in the wrist joint has disappeared. As I said before, well, the anatomy, because you use MRI, is not a problem because the technique is applicable to all anatomies that you could think of. And here you have a short overview of an osteoarthritis patient, a rheumatoid arthritis patient in low disease activity, a rheumatoid arthritis patient with activity in the midfoot and in the Achilles tendon bursa, as well as in activity in the rheumatic nodule in the heel pad, and then a psoriatic arthritis patient where you see capsular enhancement, saucer digits with subcutaneous enhancement, as well as nail bed enhancement, and not wrist and MCP joint involvement, but involvement of the dip joint. So these maps maybe aid you to do your differential diagnosis, because this patient was first classified as a seronegative rheumatoid arthritis patient, but based on, let's say, some clinical features, but also on these imaging findings, they were reclassified to be a psoriatic arthritis patients on a later stage. Well, if you go away from the hand and now look at the knee joint, then there are some obviously advantages of using dynamic contrast enhanced MRI if you want to assess the regional activity, because usually what you do when you assess knee joint with synovitis, this is a reactive arthritis of a knee with a flare up, and the problem is that if you assess this, usually you assess the suprapatellar pouch. But the problem with the suprapatellar pouch is that if you place your region of interest in that, you'll see you have a quite flat enhancement curve because of low perfusion. But if you place your region of interest behind the knee joint in the capsule, where the tendons inserts, also you actually see that you have a very, very steep enhancement curves that are even steeper than the corresponding artery behind the knee joint. And so this will help you if you want to, let's say, go for biopsies, then why don't you go for the most perfused areas instead of having a more standard approach where you usually take the biopsies in the suprapatellar pouch because they're more easily assessed. Another, let's say, thing you can use it for is if you want to take biopsies in cancer, then why don't you guide yourself based on the perfusion curves to actually take the biopsy in the areas with the highest perfusion, which probably would help you assessing the vital tumor part of cancer. You can also use the DCE-MRI approach in bone marrow infection or osteomyelitis. And this is a secondary osteomyelitis after a knee arthroscopy. And what you see is that the needles of the osteomyelitis, the curve from that is steep and with a high plateau. It's similar, but with a less plateau, or a little bit less plateau in the inflammatory synovial lining. But the bone marrow lesion, where you actually have it surrounding on the periphery of that osteomyelitis, will give you a high bone marrow signal on the static or fluid-sensitive sequences, but a less steep enhancement curve. And this opens up for understanding or potentially using the flow curve, the DCE-MRI curve, to separate the reactive or repair tissue from inflamed or infected tissue. If you want to do K-trans also in the joint, which a lot of you probably have a lot of experience with, then if you go for free Tesla, then you can cover the full joint and you can have a good arterial input that you can use as your arterial input function. You can also go for the vein and you can look at the time interval between if you want to calculate some of the perfusion measures that the K-trans enable you to do. One of the good things about this tool is, and this approach is also, that you can, for both clinical but especially at this moment for science purposes, you can extract measures of disease activity, both the volume of enhancing voxels, the behavior of every voxel, to give you a more dynamic and patient-specific inflammatory load than the conventional scoring systems would allow you to do. While crossing the bridge from the inflammatory joint diseases to the degenerative joint diseases, exemplified in this knee joint, where you usually don't give intravenous contrast, you can see that this is a typical osteoarthritis case. You see joint space narrowing, osteophyte formation, menisc degradation and extrusion from the joint. You see a bone marrow lesion in the tibial plateau, a little bit also in the femur of the medial joint compartment. You see cartilage destruction, and if you do a sagittal view here through that bone marrow lesion, you will see on the fluid-sensitive sequences that the bone marrow lesion is quite big. You also note on the fluid-sensitive sequences that there's a big effusion and some thickened fibrillated synovium, as well as an increased signal in the fat pad of Hoffer, or the intrapatellar fat pad. There's a bone marrow lesion in the patella, along with some cartilage reduction, and there's increased signals in the pre-patellar bursa. When you give contrast, you're more able to separate the enhancing synovium and the enhancement in the fat pad of Hoffer from the surrounding fluid. Because on the fat-saturated T1, after contrast, the fluid will be hyperintense, whereas the bone marrow lesions are in the same terms of how it looks like, the same as in the fluid-sensitive sequences. But mapping it with DCE-MRI will show you that there's a big difference in the behavior of contrast in the different regions of the joint. And as we've learned in the inflammatory joint diseases, a lot of the disease happening in the synovial membrane, and they have a more homogeneous enhancement in that synovium, whereas in osteoarthritis, it's a more focal, more spotted enhancement patterns with local areas of high perfusion and areas with a lower perfusion. And this might be able to explain the fact why we have had problems with assessing what is actually happening in the synovium and in the bone when you do a biopsy from those areas because of this typical osteoarthritis appearance. But doing the DCE-MRI, you will probably give you an aid in assessing the highly perfused areas and also enable you to have a more dedicated biopsy approach. And what you notice is that there's a very big perfusion in the subchondral bone area, as well as a very high perfusion in the part of the interfallopian fat pad. We did a study where we gave contrast to osteoarthritis patients, and this was done in approximately 90 patients, obese patients in a diet intervention study. And usually you don't give contrast to osteoarthritis. So, but by doing it, we had the chance to do the DCE-MRI data, and we tried to look at what happened in the interfallopian fat pad, or the fat pad of the Hoffa, to see whether the static scores after contrast or the dynamic properties in that fat pad could have a better associations with the patient's knee pain, as it has been shown that the fat pad is highly active and produces pro-inflammatory products and cytokines. And this is the setup. We did the post-contrast T1, which was a gradient echo three-dimensional sequence with a 0.6 isotropic resolution, enabling us to do reconstruction in all planes. We did an axial view of the DCE-MRI covering the extra the fat pad area, and we encircled the fat pad with a region of interest in all the slices. As you can see, this was the enhancement from all the slices. We summed the slices to one particular slice and or a mean enhancement slice, and then we had a very high inter-observer variability, we had a very high ITC, meaning a very low inter-observer variability with the DCE-MRI approach, whereas the static score had, well, a 0.6 ICC, which also corresponds to the literature when you do static MRI scoring. This is an overview of how it looked like, a grade 1 or 0, 1, 2, and a 3 on the static post-contrast images, and then the corresponding DCE-MRI data with initial rating, initial rate of enhancement maps, and maximum enhancement maps. And what we then found was this, and this obviously in a cross-sectional setting, was that if we looked at the clinical scores of the patient using the KOOS subscale of pain, symptoms, activity of daily living, and quality of daily life, as well as sports and recreation, we saw that if you scored the synovitis based on the enhancement properties on the static post-contrast scores, you saw a low correlation to KOOS pain and to symptoms, but no correlation to activity of daily living, quality of life, or the other, or sports recreation. Whereas when you looked at the DCE-MRI data called inflammations, where we multiplied the mean of the initial rate of enhancement curves with the volume of enhancing voxels within the fat pad of a Hoffa, we saw suddenly up to 0.51 correlation to patient symptoms, which gave us the conclusion that if you look at the perfusion in the tissue, you approximate, or you have a better associations to the experienced symptoms of the patient. And this has been published in Osteoarthritis and Cartilage with the EPUB ahead of print in May of this year. We can also try to assess other entities of the bone, meaning the bone marrow or the synovitis with this, and this is work in progress. But again, you have to overcome the obstacle of giving intravenous contrast to patients with osteoarthritis. But it makes sense, as osteoarthritis in more and more more and more research points toward that osteoarthritis is driven, at least by some part, by the inflammation in the joint. Well, the latest results of using Dynamica is that, well, first of all, we establish it as a method that could be used, and the algorithm incorporated in the Dynamica software will reduce the motion artifacts and also ease the assessment of the synovial inflammation. It was a much robust and reproducible approach even over time, especially compared to how you usually did it with eyeballing of the most enhancing part with a manual placement of a single ROI. Then by using the dynamic MRI maps, we had a very high reproducibility of the same results, so giving us robustness in our analysis. It has also been shown not only in patients with inflammatory joint diseases, but also in healthy, that the dynamic MRI contrast enhancement properties are showing some signs of enhancement even in healthy, but they are stable and fluctuates within 5% over 1 year. We have also shown that the dynamic MRI derived parameters correlate highly if you do a wrist ROI with the corresponding ram wrist synovitis and bone marrow edema score. And we published that in Rheumatology in 2012. We've also tried to, let's say, explain how we interpret these dynamic curves in a review article in Arthritis from 2011, where we also, let's say, used the previously shown knee joint case as a reference for explaining the potential use of the technique. We have reproduced the data from 1990s with this approach, and also found a very high correlation to the histological grade of inflammation from biopsies in the knee joint, and where we showed that there was a 0.74 correlation to the pathological grading in the microscope. It was also shown by Mette Axelsen and co-workers that there was a very high reliability and responsiveness of these dynamic MRI curves following intra-articular steroid injection in the knee joint, which means that you see fast changes when you reduce the inflammation in the patient cohort. This has also been shown to be a potential tool for assessing psoriatic arthritis, even though it's more difficult because the psoriatic arthritis lies in the capsule more than in the synovium, which gives you some obstacles if you have to separate vessels in the subcutaneous area from the corresponding enhancement in the capsule. But it's a useful tool and seems to be important. Recently, this year, there was also published that the dynamic MRI curves identified the patients that had a clinical response in a better way than the conventional static scores. So it seems that, let's say, the fact that if you've had the disease for some years, well, the static score doesn't change as much. This is particularly an area where the perfusion curves seem to make a big impact on interpretation of treatment response. There are some recommended reviews, even though they're a little old, of how you assess inflammatory joint diseases. with X-rays and with the new computerized methods that I recommend you to read and study. So summing up, some of the advantages of using MRI in rheumatoid arthritis is that dynamic MRI is stable over time in healthy subjects with less than 5% variation over 1 year. Dynamic MRI in rheumatoid arthritis can also show an immediate treatment effect even before it's visible on conventional MRI images, and as recently shown, it also seems to show a response in less perfusion in patients that have a clinical response to rituximab treatment in a better way than the conventional scores. Dynamic MRI in rheumatoid arthritis correlates highly with the ultrasound Doppler on 3 Tesla, and dynamic MRI correlates highly with the Rambus scores of inflammation on all field strength available. But remember again here that do not cross over with the same patients in different scanners. Keep the patients in the same scanner. Dynamic MRI also provides you reliable and responsive measures using Dynamica, and the initial rate of enhancement correlate highly with the histological grade of inflammation in rheumatoid arthritis knee and can separate healthy controls from rheumatoid arthritis patients. Dynamic MRI from patients with inflammatory arthritis can be analyzed using Dynamica in a step-by-step easy way. Not only does this enables us to assess inflammation in inflammatory joint diseases, but it can also provide important information in degenerative joint diseases and give a better clinical correlation than the conventional static scoring systems. Thank you for your attention, and hope that you can use this short introduction to work further with dynamic MRI. If there's any question, please let us or let me know, and I'll be happy to answer.
Hello, I'm Mark Hinton, the CTO of Image Analysis, and today I'm going to talk about modeling pharmacokinetic parameters with Dynamica. So here we have the pharmacokinetic parameters screen, and here is an image of a cervix. So we can see we can scroll through the slices and see those. I'm just going to go back to slice 5 where I've drawn a region of interest, and we can also scroll through the time frames. And what we see here is a region of very early enhancement, so this would typically be an area that is either a blood vessel or very highly perfused. So if we hover here, we see on the right hand side in the intensity graph the classic shape of a blood vessel signal intensity curve, where it responds early, reaches the peak very, very quickly, as you can see, then it drops off fast and then tails off slowly. This is typical of a blood vessel, and this would make a good arterial input function, which I can choose by double clicking when I'm in Roy drawing mode to select it and then saving the AIF. Let me just do that quickly. So I've created a point of interest here that I can now save as my arterial input function, which is shown over here. As we continue to scroll through the time points, we see that more things begin to enhance. You can see the shape beginning, and as we get right to the end, we see even here that the water in the bladder is now enhancing. That's the last thing to enhance. Pharmacokinetic parameters attempt to model the flow of blood and the perfusion of blood in the human body. It assumes that there's a transport function across a membrane. So we implement a 2-compartment model which says that blood is perfusing from vessels into tissue. There are a number of parameters that go into modeling this, and first of all I'm going to take you through those parameters. The idea behind pharmacokinetic modeling is that one can model the flow of blood across a membrane by looking at the signal intensity curve on a dynamic scan in the blood and comparing that with the signal intensity from a dynamic contrast enhanced examination in tissue. Over here on the right of the screen we can see the input parameters required to do this kind of modeling. First of all, there's a parameter called the T1 relaxation time of blood. This is typically around 1400 milliseconds, but can be set to the number that, if you have a number that you know is accurate for your patient, you can use that. We also need to understand the T1 values of tissue. Now, these can either be calculated from a sequence of MRI scans taken with different flip angles and reconstructed. If it sees that there is a series of variable flip angle sequences, then it will calculate a T1 map automatically that you can use. If you were to go to that and choose it, you would have to choose the map. This particular series has no map available, I'm afraid, so I won't be doing that on this series. Otherwise, you can enter the T1 value for tissue manually. Here we have a value of 800 milliseconds, which is kind of typical of most tissues, but yeah, will vary between different parts of the body and different patients. Having settled that, the third thing we need to decide on is arterial input function. So this is the shape, similar to this shape here shown in the graph here, of the signal intensity curve inside an artery, inside a major blood vessel. So we have two ways of doing it. We can select it from a point, and in order to do that, I would simply select a suitable point, such as that, and then save the value by clicking save. If I get rid of that point, to do that first, get rid of that point, then I can see this saved arterial input function. What I can do, if I'm not happy with that curve, if I think there's noise or a bad point on it, I can actually pick an individual point and drag it to a new position. So if I select a point and it's a good shape for my arterial input function, but there is a bit of noise on it, I can deal with that noise if I wish to. The other option is not to use a point, but to use a population function. So we've implemented a Feynman model, which is a bi-exponential arterial input function, and in order to do that, we need to know the dose in millimoles per kilogram of contrast agent that was used. That would typically be around 0.1 to 0.2, 0.2 here, and the peak frame. This tells us exactly when the concentration reached its maximum, and I can get that from probing around to try to find something that looks like a blood vessel. And in this instance, this looks like a blood vessel. I would choose peak frame 3. And that's essentially all I need to do to be ready to calculate. I can change the relaxivity of the contrast agent. There's a default value of 4.5. We have a table here of many popular, commonly used contrast agents, and the relaxivity values as a function of magnetic field strength of the scanner. So I'd now be ready to simply go ahead and calculate. Now, one of the things I have done here also is I've decided to restrict the calculation just to regions of interest. Why do we have this feature? Why have I done that? Well, unlike the parametric modeling that you may well have seen, you should have seen earlier, the pharmacokinetic parameter modeling is highly computationally intensive. It's pixel by pixel, every single pixel, and it does take, even on a powerful computer, it takes a long time. So, as you're generally not interested in every pixel in every slice, you're really only interested in a region of interest, in a tumor, in a lesion, in an area of disease. We've allowed you to mark up that region of interest roughly first, and then just calculate within. Even so, it still takes a few minutes to calculate. The good thing is that Dynamica being a web-based system, you can set it calculating and then go off and do other things. Not just make cups of coffee, but you can still use Dynamica on other series and set them up and get them running. Everything will run in the background and you'll be informed when the calculations are finished. So rather than keep you hanging around for just 3 minutes or so while this would calculate, in the best traditions of television, there's one that I prepared earlier. Here's the one that I calculated earlier. I can come down here to frame 5, where I have a region of interest, and we can see the various parameters here. So we have 3 maps associated with pharmacokinetic modeling. The first one is K-trans. So this is the rate constant between blood and the pixel in question. So the higher the value, so the brighter the map within this region of interest, then the lower the barrier is for blood to go into that pixel. That usually would imply a higher vascularization or inflammation. We also calculate the volume of extracellular space in the region. So this is the interstitial space between cells. Again, this would be indicative of this could be indicative of inflammation. There's a lot of fluid in between the cells, or it could actually be indicative if it's a very high value that it's actually water. In fact, just over here, although we don't really show it, would be the bladder, and that would appear as a very high volume of VE because there's basically no cells there. It's just water. The third map that we calculate is the initial area under the gadolinium curve, 60 seconds. This is a slightly arbitrary but commonly used measurement. So we calculate the concentration of gadolinium in each pixel at each time point, and this is the integrated area under that curve up from 0 to 60 seconds. It shows very similar patterns to K-trans. What we can see in the graphs on the right-hand side is we can see the saved AIF value that we used. If we come back over here, we can see the signal intensity at where the crosshair is, and as we move around here, where we've had a calculation in the lower graph, and it's a little hard to see. The slightly red thing is the fit we've made to the signal intensity curve, and you can see the other ones. We've got the saved AIF value and the probed value of. So all of these let us see how good the calculation has been. Unlike the parametric calculations, where basically there isn't so much of a quality of fit. With the pharmacokinetic parameters, the calculations are much more sensitive to these and spikes on the input signals. So it's in some ways it's a less robust technique than the parametric series, but the advantage of the pharmacokinetic is that it is measuring physical numbers. It's a fractional volume. It's a real transport coefficient with physical units that's being measured. So in principle, it's more easy to compare it across scanners, across patients. In our experience and some of the work that we've been doing, it's really becoming apparent that the difficulties of the modelling and choosing which terms to include and which ones you could ignore actually point to the parametric calculations being just as good and much easier and faster to calculate and requiring less user input. As you've seen earlier, we have to do quite a lot of inputting of information here. Although we've set defaults as much as we possibly can to make it easy for you to use, you need to know if those default values in your particular case are valid for the images that you're looking at. So there you are. That's essentially how you run through and set up the parameters to calculate pharmacokinetic parameters on a dynamic series. All of those, the numbers that are calculated are reported, as can be seen down here. K-trans, VE, and the initial area under the curve are all reported along with the parametric, and they can be saved to Excel files or in PDF reports, as can all the other stuff. So I hope that's given you just a little flavour of the pharmacokinetic parameter modelling capabilities of Dynamica. And it would be interesting for you to, I think, to try this out and see how it compares with the parametric maps. And we're always here, of course, to help you understand what you're doing with your data. Thank you very much.